Welcome to the channel Speaking Steth. Today we are going to discuss about congenital tubular disorders. So we mainly focus on Butter syndrome, Gentleman syndrome, and Liddle syndrome. So Butter syndrome mimics loop diuretics usage. It is a rare disorder and autosomal recessive inheritance, and it is the mutation of sodium potassium 2 chloride pump and renal outer medullary potassium channel in thick ascending loop of Henle. So, if there is mutation in sodium, potassium, and 2 chloride channels, it leads to loss of these electrolytes in the urine. It leads to depletion, volume depletion, and it activates renin from kidney, and this renin in turn activates RAS mechanism. RAS mechanism leads to aldosterone release from the adrenal gland, and this aldosterone acts on collecting duct and DCT to reabsorb sodium into the lumen into the cell and thrown out potassium into the lumen. So in that way hypokalemia is present. So we can see here the renin release. So there will be increase in serum renin levels, and there is aldosterone release. So increased levels of aldosterone in the serum in Bartter syndrome. And there is one more thing called hypercalciuria. And before discussing about hypercalciuria, we also seen the aldosterone not only promotes the absorption of sodium, it also promotes the S plus secretion and K plus excretion. So it causes metabolic alkalosis. So we see hypokalemic metabolic alkalosis in Bartter syndrome. Then let's talk about hypercalciuria. How hypercalciuria is associated with Bartter syndrome. So if we see here, here it is the channel of sodium potassium 2 chloride. So usually the function of sodium potassium 2 chloride transporter is to reabsorb sodium, potassium, and chlorine through this channel into the cell and into the blood. And there is one more channel called ROMK, renal outer medullary potassium channel. The function of this channel is to push back the potassium that is being reabsorbed through the sodium potassium chloride channel. So it pushes the potassium into the lumen, and it creates the positive potential in the lumen, which is guiding force for calcium to get reabsorbed. So if this is defective, the potassium is not being pushed into the lumen, and there is loss of gradient for the calcium absorption. So the calcium is not being absorbed and getting lost in the urine. Will be more calcium. It leads to hypercalciuria. So it leads to renal stones. So the tubular disease which is associated with the renal stones is Barter's syndrome. So this is the mechanism actually, and we can see hypokalemic metabolic alkalosis. We discussed it already. And there is one more entity is SNHL, sensory hearing loss, will develop in some of the Barters. So Barters usually are 5 types. In type 4, we can see SNHL along with other symptoms because same sodium potassium 2 chloride channel present in the inner ear endolymph. So what are the treatment options for Bartter syndrome? We can use ACE inhibitors and ARBs and potassium supplements and magnesium supplements, fluid balance to correct the uh, hypovolemic status, and avoid aggravating drugs like loop diuretics loop diuretics, and NSAIDs. And the next one is Gentleman syndrome. So in Gentleman, if we observe, M and G is there, and Mg is for magnesium. Magnesium. It mimics thiazide diuretic uses. It is also a rare disorder. It usually manifests in late childhood or young adult. It is also an autosomal recessive disorder. It is due to defect in sodium chloride cotransporter and transient receptor potential membrane M6, which is responsible for absorption of magnesium, and it is present at distal converted tubule. And mechanism is same as Bartter syndrome. Sodium chloride loss leads to hypovolemia, which leads to renin release, then aldosterone, then it acts on CD, collecting duct and DCT, and it promotes the sodium absorption and H plus secretion, K plus excretion. So same as the Bartter syndrome. And obviously there is increase in the renin and aldosterone. And here if we notice, gentleman grabs calcium, so there is no hypercalciuria in gentleman. So hypercalciuria is specific to the Bartter syndrome. So, and there is hyperkalemic metabolic alkalosis like Bartter syndrome. So if you see here, this is the NSCL co-transporter, and due to its mutation, sodium and chloride is not being reabsorbed here, and it is TRMP MPM6 channel. So due to its defect, magnesium is not being reabsorbed and it is being lost in the urine. So there is hypomagnesemia is present. So the serum magnesium levels will be low. Treatment options same as Bartter syndrome: potassium and magnesium supplements, and avoid triggering drugs like thiazides, thiazides, and we can use potassium sparing diuretics and decrease salt intake. And there comes another disease called Liddle syndrome. Liddle syndrome, it is pseudo hyperaldosteronism, also called as pseudo hyperaldosteronism. Liddle syndrome is little bit of different from the previous two diseases. It is also a rare disorder, but it is autosomal dominant. Butters and Gentleman's are autosomal recessive inheritance. It has autosomal dominant inheritance. And also in Butters and Gentleman, we see the defect in the channels. Here there is gain of function, mutation of ENAC. So here the ENAC channels are overexpressive. So overexpressive ENAC channels leads to lots of sodium reabsorption, which leads to hypertension. So this hypertension suppresses aldosterone release. So this entity gives the picture of hyperaldosteronism, but in reality the aldosterone levels are low. So it is pseudo hyperaldosteronism. It leads to increase in the absorption of sodium into the blood, which leads to hypertension and also loss of potassium ion in urine. So it leads to hypokalemia. So hypokalemic metabolic alkalosis is common in all three. And the significant feature is early onset hypertension, and amyloid is the ENaC blocker is the treatment option for Liddle syndrome. The key point is here, while solving MCQs, we must remember few things. So in Bartter syndrome is mimics loop direct uses. it is associated with hypercalciuria because loop loses calcium, and we know the mechanism already. So hypercalciuria is typically seen in Bartter syndrome, and it is the key feature, and it helps us to distinguish it from the other two and to help us to score the MCQ. So in Gentleman syndrome, we know G and M. Mg, it is for magnesium. So hypomagnesemia is the characteristic feature in Gentleman syndrome. There is very slight hypomagnesemia can be seen in Bartter syndrome also, but hypomagnesemia is more associated with Gentleman syndrome. It is hypo, not hyper. Then Liddle syndrome. Liddle syndrome is associated with hypertension. So if we get hypertension in the question and it is a tubular disorder, then we should think of it Liddle syndrome. If we get renal stones in the question or hypercalciuria, so we should think of Bartter syndrome. If we have hypomagnesemia in the question and the question is about tubular disorders, we should think about Gentleman syndrome. If we can make out these three, we can easily solve the MCQ. Thank you. Please subscribe.